We are live.
Good evening, everyone. So I'll be welcoming you all to yet another class of iFocus Online, which is lecture number 531 in the series and the sixth in Optics and Refraction. So today's class will be presented by Dr. Vaibhav Nagpal on Geometrical Optics under Refraction. So let me welcome the moderator for today's session, Dr. Zain Khatib. Sir did his MBBS from Seth GS Medical College and KEM Hospital, Mumbai, and MS in Ophthalmology from Karnataka Institute of Medical Sciences, Hubli. Sir is a medical director and consultant at Khatib Eye Clinic and Perfect Vision Laser Center at Mumbai. He's fellowship trained in phaco-refractive and advanced anterior segment surgeries from Lakshmi Eye Institute, Mumbai, and Moran Eye Center, Salt Lake City. He's a prominent faculty and presenter in various state, national, and international ophthalmic conferences and has been active part of various ophthalmic bodies. Currently, he's an executive member in EOC. He's a managing committee member of BOA and JC committee member of MOS. Sir is also recipient of various international and national awards over these years. Next to introduce is none other than Major General Dr. Sagarika Patel. Ma'am is the chairperson for today's class. Ma'am has done her MBBS from Calcutta Medical College, DO and MS from Army Hospital, Delhi, and has had her glaucoma training from RPC AIMS, New Delhi. Ma'am is a gold medalist, has also Frank Corner Silver Casket for standing first in surgery in the Calcutta University. Currently, ma'am is a senior consultant at Center for Sight, New Delhi, and has also served as Assistant Chief of Integrated Defense Staff Medical at Army Headquarters, Delhi, has also been HOD of Ophthalmology at Army Hospital and Army Base Hospital, Delhi, and has been a professor at AFMC, Pune. Ma'am was the only lady officer to have commanded the world's highest general hospital at Leh, where she was instrumental in establishing telemedicine nodes in high altitude to help soldiers stationed in the highest battleground in the world, which was at Saigon. Ma'am has received the Vishisht Seva Medal, Sena Medal, Chief of Army Staff Commendation, among many other prestigious awards. Ma'am has been active in research, has more than 49 publications, both in national and international journals, and has written chapters in various books and has edited a book which is Resolving Dilemmas in Perimetry. Ma'am is also recognized as a supervisor to guide PG and diploma students, undergraduate and postgraduate teacher and examiner. She has also served as MCI Inspector for MBBS DNB, National Faculty for Glaucoma, and Faculty in DOS PG Teaching Program. She's also served as a referee for MJAFI Index Journal, reviewer for Clinical Ophthalm and DJO. And finally, introducing our speaker for today's class, Dr. Vaibhav Nagpal. He's done his MBBS from Seth GS Medical College and KEM Hospital, Mumbai, and MS Ophthalmology from Maulana Azad Medical College, Delhi. He's also done his fellowship in cornea from LVPI and has also FICO degree in Edinburgh. He's currently a faculty at Shantilal Sanghvi Eye Institute, Mumbai in cornea and anterior segment services. He's got various awards and has numerous publications in both national and international journals and has also participated in various national and international conferences. Over to you, Dr. Vaibhav.
Thank you for such a kind introduction. And I would like to thank iFocus for this opportunity. I'll be sharing my slides right now. Are my slides visible?
Yes, you're visible.
Are they moving? Not, right?
No.
Yeah.
Now.
So I will be talking on the topic of refraction on geometric optics. So I've kept it very simple, and let's move with the presentation. So what is refraction exactly? It is change in the direction of light when the light passes from one transparent medium into another of different optical density. So why is the light changing its direction? So to understand that, we need to first understand the concept of refractive index. So how do you know the refractive index of a medium? So, and how do you calculate it? So it is dependent on the velocity of light in that medium. The velocity of light actually varies according to the density of the medium through which it travels. Let's look at this picture. Here, the light is traveling first through air. You can see the wavefronts. The wavefronts are widely spaced. And when the light enters the denser medium, that is glass, the space between these wavefront decreases. So here the light is becoming slower. But when you see that the ray of light is actually perpendicular at the interface, so it is not deviating. So now what is refractive index we have discussed. So what is absolute refractive index? When you compare the velocity of light in vacuum to the velocity of light in that medium, that is called the refractive index of that medium. But we cannot compare normally in our daily lives. So for all practical purposes, the refractive index of any medium is defined by comparing the velocity of light in air and to the velocity of light in that medium. So these are the common refractive indices we should be aware about. So air is normally considered for all practical purposes as 1. Aqueous has 1.33. Cornea has 1.37. Here we need to closely see what is the difference between the refractive index of aqueous and cornea. We'll have to apply this concept later. And also crystalline lens, which is about 1.386. So there is very minimal difference between aqueous, cornea and crystalline lens. Moving ahead, when this light, so when you see on the right side of this image, the ray of light is perpendicular to the interface, so it goes undeviated. But when this ray of light obliquely strikes the interface between N1 and N2, there is deviation of light. There is change in path of this light. So this is actually determined by the refractive index of the medium, also the wavelength of the light. So let's see what are the laws of refraction. So the incident ray, which is so the incident ray, the refracted ray, and the normal, that is the perpendicular, all lie in the same plane. And the angle between the incident ray and the normal is called as angle of incidence. So this angle of incidence and angle of refraction are always constant according to the medium at for that, and that is how you calculate the refractive index of that medium. So that is the second law of Snell's law of refraction, that the angle of incidence, refraction are related to the refractive index of the medium. So now moving ahead in the concept, so when a ray goes from a rarer medium to a denser medium, that is, for example, when the light is traveling from air into cornea or glass or aqueous, it will be deviated towards the normal. Why? Why does this happen? So let's see another image. Here you can see that this is the beam of light which we had seen in the previous picture as well. So when this beam strikes at an angle, the part of beam which strikes the interface first is retarded. So the light is traveling from a rarer medium to a denser medium. So the beam of light which strikes it first is retarded. That's why, and the part of beam of light which is going to strike the interface later is in the normal speed. So when the part which strikes is retarded, the light actually deviates towards the normal. The same happens when the light is traveling from a denser medium to a rarer medium. When it goes at the interface, the part of beam which strike first, the speed of light increases at that moment, and that is why it is deviated away from normal. So now let's see what happens when the light passes through a glass plate. Here we have already learned about our concept of the light deviating towards normal. So here is air and here is glass. The light is traveling and it deviates towards the normal. And then when it emerges from this denser medium into a rarer medium, it is deviating away from normal. So what happens to the ray of light? So this ray and this ray, the direction is same, but the emerging ray is now laterally displaced. So this is the concept which we need to understand for the further part of the presentation. Moving ahead, whatever light strikes at any interface, 100% light never passes through the interface. We will not talk about the percentage of light which is absorbed in the surface. We'll talk about a part of light is always reflected at any interface. For example, a light beam strikes at the first interface, about 4% is reflected. And when this same light passes through the glass and next 4% is reflected. So the final light which actually reaches on the other side of the glass is about 92.16%. But why are we learning this concept right now? So we use this concept in all our instruments basically to get. So this concept is being used in the teaching microscopes, in the teaching scope of the indirect ophthalmoscopes. So whenever you see a microscope, it has a side scope where the person on the side can see the image, the same image what the surgeon is seeing. And we also have a second outlet which is actually put into a recorder. So how does the same image is being transferred to three different areas? So the concept of reflection of light of some part of the refracted light is being used to cast this image into these observing side scopes and for image recording. So whenever we buy a microscope, we always discuss with the seller also that how much percentage of light is actually going to be transferred by this beam splitter into the teaching microscope part. Because if a lot part of it is transferred, the image will become dim and your illumination will decrease. So this also we have to understand when we are buying new microscopes, and how does this beam splitter helps us. Moving ahead in the presentation, we will talk about refraction of light at a curved surface. This is where we are entering into our cornea part, so, or in the eye basically, because the anterior surface of the cornea is curved, the anterior surface of the lens is curved. So this part of refraction is very important. So here N1 is less than N2. So the parallel beam of light is now striking a curved interface for the second medium. So second medium here is N2, which is we can assume as cornea. So considering the light is passing from a rarer medium into a denser medium, where it is going to deviate? It is going to deviate towards the normal. That is why a convex refracting surface is actually going to converge your rays, but provided that the N1, that is the light from rarer passes into denser. But for example, if the light passes from a denser medium to a rarer medium, it will actually deviate the light and it will have a diverging power. So how do you calculate the surface power of cornea? So basically we subtract N1, that is the medium from which the light is coming, from the refractive index of the second medium, divided by the radius of curvature of this curved surface. So the surface power is positive for converging surfaces and negative for diverging surfaces. The anterior surface of the cornea is an example of converging surface and accounts for majority of refracting power of the eye. So how does cornea account for majority of refraction? We do have a lens also, and it is supposed to have more power. But because of difference in the refractive index, let's go back to the same table which we had seen previously. So here we see that the refractive index of air is 1, aqueous is 1.33. So when the, and the tear film also is about similar. So when the light strikes at the cornea tear film air interface, the difference between N2 and N1 is much higher compared to when the light will strike from aqueous to the crystalline lens. So here when the light will strike from aqueous, that is 1.33, the difference between crystalline lens and aqueous, the difference in the refractive index is very minimal. It is about 0.05 to 0.07 or 0.08. So the difference is less. So the amount of refraction which will happen at that interface, which will be much lesser compared to the refraction which is happening at the air and cornea interface. This also explains us that the IOL power which we see is actually calculated outside the eye, and the IOL power, the amount of power it contributes in the total refraction is different, because that will be calculated when the light strikes from aqueous to the intraocular lens. So when you go back and you see the Gulfstran's reduced eye as well, The lens actually contributes only 15 diopters in the total power of the eye, and the cornea contributes about 43. 48 is the anterior surface, and negative will be -5 diopters. So that is because there is a difference in the refractive index of the two media at the interface. So now, how do we apply this concept in our daily lives, and how we can appreciate this concept, what we have learned right now? I am repeating again and again: denser medium, rarer medium, denser medium, rarer medium, how the light is traveling. So objects in optically dense medium appear displaced. We all have seen those stones in the rivers or swimming pool. If one of our friends put some object and we try to get that object and we are not able to get it, we think that we appreciate that the object is actually, it appears closer than it actually is. So here is the concept of refraction. For example, if you see the image on the left side of the slide, the object is actually at the base of the swimming pool, but the light is traveling from a denser medium to a rarer medium. So now the light is going to deviate away from normal. But when the observer sees that object, that source of light, it is actually coming from a closer surface. That is what our mind will appreciate because of the direction of light. That is why this object will appear which is closer to the surface. So the concept of apparent depth and actual depth comes here. Same goes for fishes. When you go for hunting, they may appear closer than they already are. The same can be applied for an object which is partially outside water and which is partially inside water. The image will actually look discontinuous or crooked. So this part of pencil is actually outside water and this part of pencil is inside water. So the rays are deviating away and they appear to come from this part. That's why the pencil will appear crooked. So now, how do you apply the same concept in ophthalmology when you are when you are operating? So in the aqueous, we already discussed. So the refractive index of air is 1. The refractive index of aqueous was 1.33. So now the rays are actually coming from optically denser medium to optically rarer medium. Correct? The difference between cornea and aqueous is just 0.04. So we won't take that into account. So the instruments actually appear closer to the cornea than they actually are. So if you want to do phacoemulsification in the right plane, you should actually use the other cues which are there in the eye. For example, it is always taught to us that there is a safe space that is in the pupillary plane and in the rhexis plane in the center to do phacoemulsification. So what you can do is you can actually, while emulsifying the phaco pieces, you can see if the edge of the piece is touching the rhexis or is in the pupillary plane. That will give you the correct idea about at what depth you are operating rather than relying on your own sense of depth. Definitely that is important, but this is the geometric optical phenomena which is governing that thing. So moving ahead with the next concept. So we are continuously talking about when the rays travel from a denser medium to a rarer medium. We already know that when the angle of incidence is 0, the ray will pass undeviated. And slowly, when the angle of incidence increases, it starts deviating away from normal. So there is an angle which is known as critical angle. So when the rays become more oblique, that is when they strike the surface at an oblique angle, there is an angle at which the ray will be parallel to the interface. That is known as a critical angle. Any ray which strikes at the interface at an angle more than the critical angle will actually be reflected inside the medium and will fail to emerge from the interface. So this concept is important for daily living also and for our ophthalmology. So the rays striking more obliquely fail to emerge from the denser medium and are reflected back. The critical angle is actually determined by the refractive indices of the media involved. The critical angle for tear film air interface is about 48.5 degrees. Now let's move ahead with the application of this principle. So we all understand about fiber optic cables, and we know how important they have become right now for telecommunication and for our ophthalmic instruments as well. So these optical fibers basically transmit light signals and these electromagnetic waves. So because the concept of total internal reflection, they are able to do that. So if you understand that the outer coating of these fibers has a lower refractive index compared to the inner coating, that is, the outer cladding is of lower refractive index. So here the rays are traversing from a denser medium to a rarer, that is the medium in a lower refractive index, and all the rays which have an angle more than critical angle will be internally reflected. So here you can see that these are the rays which are totally internally reflected, and they can be transmitted without any loss of the energy of the light rays. This thing is used in light pipe, in our slit lamps, all of these areas to transmit light. It is also being widely used in endoscope. That is how endoscopic surgery have become so rampant, because of this one concept, that through the endoscope we can visualize everything and we can do the surgeries. It is also used in diamond. Basically, the more the number of cuts any diamond has, the more it is shiny. How? So when the light enters a diamond, it actually undergoes total internal reflection multiple times at various facets. So the more the number of facets, more will be the reflection, and brighter will be that diamond. So that is where total internal reflection happens. Now, how do we apply this concept in ophthalmology? So total internal reflection occurs at cornea and air interface when the light emerges from the eye at a certain angle. So for example, if you want to visualize the angle, but we remember that the critical angle for cornea, air and cornea interface was about 48.5 degrees. But when you try to visualize the angle, this angle is more than 48.5 degrees. So that is why we are not able to see the angle from on slit lamp directly. So how do we tackle this? And we are also not able to see the peripheral retina, because from our normal 90D lenses or our 78 diopter lenses. So this problem actually can be tackled by changing the interface. Why is the total internal reflection happening? Because the rays are emerging from a denser medium into a rarer medium. What if we change this interface and we keep a optically denser medium, that is denser than cornea? So when we keep a gonioscope, this glass has a refractive index which is more than cornea. So when the refractive index is more than cornea, the rays won't deviate away from normal, but they will deviate towards normal, because now cornea is a rarer medium compared to the denser glass medium. So now the rays will deviate towards the normal, and a mirror can be used to see those parts of the angle. The same concept is used in the three mirror lens, which is one of the mirrors, and different angulations are used for at different angulations. Those mirrors have been kept. So you can visualize the angles with this three mirror lens. You can also visualize the peripheral cornea and the mid peripheral cornea, depending on the part of that three mirror lens which you are using. Now, there are multiple other areas also in the eye where total internal reflection occurs. That umbo, which we see when you examine a fundus of the cornea, and you always say FR present or foveal reflex present. Why does that umbo shine so bright? Because of total internal reflection in that cone, that conical part of umbo, actually the light undergoes total internal reflection, and that umbo shines so sharp. The edge of surface the edge of subluxated lens can act as a area where the angle of incidence of these rays is more than the critical angle, and that can lead to total internal reflection. The oil droplet reflects in keratoconus, and the Rizzuti sign are a result of the phenomena of total internal reflection. The fifth being the sclerotic scatter. Now, let's move ahead with one of the concepts. So, till now, we have assumed that light is white. But we all understand that it is composed of various wavelengths. And for light of different wavelengths, a medium exhibits different refractive indices. What does this mean? So a light of shorter wavelength is deviated more compared to the light of a longer wavelength. Here you can appreciate that this is the white light, but it is made of 7 wavelengths, correct? So the wavelength which is deviated the most, that is violet, that is has a shorter wavelength. But when the light emerges out of normal glass slabs, all these rays come together and they again become white light when the light emerges out of it. But if you totally internal reflect these rays and they come out of a different source, they may not come together as white light, and that is the phenomena behind rainbow. And as you see in a glass prism, these rays are deviated differently. That is why you can see a rainbow out of a glass prism. And the refractive index of any substance, when we say that the refractive index of this substance is this much, it is actually standardized according to the light from a yellow sodium flame. So if you see here, yellow almost lies in the center of red and violet, about comparing the amount of deviation the red and violet light undergo when they pass through a medium. So the refractive index of any medium is actually standardized according to the light from yellow sodium flame. Now let's combine the two concepts of dispersion of light and total internal reflection. So why is the white light getting dispersed? Because the rays are getting refracted differently. The wavelengths of different light are getting refracted differently. But when these rays are totally reflected, totally internal reflected, when they emerge in a reverse fashion. So that is why you see violet color on the top and red color on the bottom. But sometimes they may get totally internally reflected twice. That is where you get a reverse pattern of the rainbow, where the red is outside and violet is inside. So here we have discussed basic principles, basic concepts of refraction. We can summarize in the last slide that we have discussed about velocity of light. Basically, it varies according to medium in which it is traveling. That is how you calculate the refractive index of each medium on the basis of the velocity of light in that. And light traveling from a rarer medium to a denser medium, it deviates towards the normal. And when the light travels from a denser medium to a rarer medium, it deviates away from normal. Some percentage of light is always reflected at the interface, and this concept is used in beam splitters and in teaching microscopes to transfer some amount of light or some part of it to the side scope for us to visualize as a student. And we also learned about the concept of apparent and actual depth. Why does it happen? Why things appear more nearer in a optically denser medium, and how to apply this concept in ophthalmology when we are operating. And the last part we discussed about the critical angle, that is when a light travels from a denser to a rarer medium, it deviates away, and after a certain angle, that is the critical angle, it will be totally internally reflected, and that is the concept behind rainbow. Thank you.
Excellent, Vaibhav. Truly, you've really, understood the basics of refraction really well, and you've been able to express everything in your presentation. And I'm sure the audience, would have learned a lot, everyone, including right from juniors to seniors, about, all the basics of refraction. Uh, Specifically, some points, that I really liked was how you went into the absolute basics of understanding why the light beam turns when you go from rarer to denser, about the change in velocity and how one part strikes the other part. And all this is something that, is important. We take it for granted that, yeah, rays, they change their direction when you go from one medium to the other. But why do they change? that is something that is, you have summarized and explained really well. I just wanted to ask you, is Sagarika madam there? Okay.
Definitely.
Yes, ma'am. Madam, you would like to give some of your comments on his presentation?
No. You continue. I have no issues, but I would definitely like to discuss because what you have just said and summarized that, he's spoken extremely well. But then again, let's dissect out some things, So anyone would you like to say some things? Then we can always have a discussion on it.
Right, ma'am. Ma'am, you can initiate the points
Okay.
about what you
So
feel.
I'll tell you what. What it struck me very nicely as Vaibhav was that you gave the refractive index of lens as not a single number. Others you give as a single number, right? Now, I'm sure it will strike the minds of our students. Why has he given a certain a certain amount, like from this it varies from here to here, and that concept is very important when the person develops cataracts. So if you could explain that, and we are willing to assist you in the discussion, then I think that is one point that definitely struck me. And second point which struck me was that, see, when we are doing very correctly, so beautifully you brought out that when we are doing when the side scopes, invariably you'll find there is somehow a little lag. You notice when taking photographs, a little lag. And of course, the image is not that clear. So when a person, for example, you're teaching gonioscopy, let's say just that, gonioscopy, and over there you find that you want to take the photograph, I mean, you want to take the video also, you'll find that there's little lag. And that second is that the clarity is not as good as when you are seeing it on the patient as when you're seeing it on the image. And that's all because the amount of light that is going through the beam splitter is definitely less. And you know what, Weber, what beautifully, because you see, none of us, we always think beam splitter. Now, beam splitter becomes just a word. But what is the meaning of this beam splitter? How does it affect? And it is so important in so many of our instruments is something which is very, very important. And I think that has been very beautifully brought out. Critical angle, again, critical angle is so important that every time we are teaching all our fellows or our DNB students or MS students that look, this is what internal reflection means. And you have brought it out extremely well because this concept is very, very important. I also want to know, which I hope you will help me out, that when, for example, you have explained that when there is, let's say, for example, you're doing cataract surgery, and you realize that it appears to be as if you're doing it you are closer to the cornea, but actually you are much lesser. I mean, you are lower out there. And then you talked about whether the cataract pieces, let's say the pieces which you are sort of dissecting out or breaking or fragmenting, that should be near the pupillary area, right? That. So this is very difficult for the juniors or the beginners to start doing because you cannot gauge. So do you have any pointers by which you can tell them that, yes, this is how you will gauge? And fun thing, interesting. You just think about when Arjuna and all of them went, and they were told that you go ahead and hit hit the eye of the fish, huh? And it which is in water. So imagine the amount of refractions that were taking place, and yet Arjun was so good that he could hit the nail, hit his arrow right in the eye. So their concept that this is where it should be when the fish is in water is something that has come from earlier ages. I, which we never even realize. We take it for granted, as you said, Zen, that,
Yes, ma'am.
we take things for granted, but that is not the case. See, this concept was there also, and it is there in our books and in our shastras. So something that we learned from was there earlier too. So, Vaibhav, if you can sort of enlighten, one is definitely the point about the fact that you've not given the lens refractive index as a figure. You've given the variation. Why?
So basically, when we move from the center part, basically where the nucleus is, the refractive index is higher compared to the periphery. And you talked about when the patients get cataract. So when they get nuclear sclerosis, the refractive index further increases. So the converging power of the eye becomes more. That's why they become more myopic, and then they come with nuclear sclerosis. They may be refracting to 20/20, but the quality of vision will be lower. So they have developed myopia, but the quality will be dull, the contrast sensitivity will be gone. So why do they suddenly develop myopia? Is because of the refractive index change in the lens which is happening.
And
And I would like,
also that is the same reason why that they start not wanting to wear near glasses when they develop.
yeah,
That is another message that should go out. So they should be told that after surgery, this near vision that you have got is going to go away when we put in a normal lens. Yeah.
Yes, and the other thing is also, then this is, साहब हम तो चश्मा निकाल के भी हम देख सकते हैं. So why are you saying that we have a cataract? So, this, what you said, Zen, was a very, very good thing. Because patients invariably, they say, जी ऑपरेशन के पहले तो हमको तो नजदीक दिखता था, अब ऑपरेशन के बाद आपने हमारा लेंस निकाल दिया, and now we can't see, and we have इतना महंगा सर्जरी हो गया. Then those concepts, I think, when we are, see how one little thing about refraction and refractive index has so much of bearing on our cataract surgeries, just this one little point. So that was one which has, I think, been very well discussed. Let's go on to some other things that you brought
I
about.
just need to bring up one more thing that we normally, I had this question always in my mind when I was in postgrad, and I think we go into fellowship and we forget about these concepts. But for example, we put a ICL or a IPCL. So the range which the company gives, that this is the amount of refractive error the ICL can correct. The range is different from the IOL power in which they are available, because the IOL power is calculated in air, but when the lens is going to go in the eye, it is going to correct a different power. Why? Because the interface in the eye, now the interface will be aqueous and the lens first. So that is what I never could understand, but when I went back in my postgrad from my fellowship days to the concept, then I could understand why they write. So I think this we can discuss, and Dr. Zain and Dr. Sagarika can.
Really, this is a very nice thing that you brought out. A very, very nice thing that, definitely when you're putting in an ICL, of course, I don't do ICL, so I don't have much of a concept excepting a theoretical concept. Navneet, what about you? I mean,
So basically,
would you like to join in this discussion?
yes, ma'am. So basically, I think with ICL, there's also a change in effective lens position. We are basically implanting a lens in the sulcus. So that is one interface. And then we have the natural lens anterior capsule as well as the interface. So surely, as Dr. Vaibhav said, that the lens position, the aqueous lens interface also acts as a like zone of refraction. And so the power that we're implanting is different from the actual refractive error that the patient has. So it's basically the concept of effective lens position and the change in the zones.
So, just two important points I want to discuss with respect to your presentation, two clinical points that I feel are relevant, Vaibhav. So, first we'll talk about is the cornea. Okay, you very nicely showed how the refraction happens from the air cornea interface. I think one thing that you did not mention or talk specifically enough is about the refraction change that happens from the cornea to the aqueous. Okay, so the refractive index of cornea is 1.37 and refractive index of aqueous is 1.33. One very, very important clinical application that comes over here is in biometry. That is the measurement of the keratometry, which we've been doing since so many years, right from the start. So from the times when we are doing your manual keratometry, we are only measuring the anterior cornea by reflectometry. I'm sure we've had reflectometry in one of the previous talks. We're measuring the keratometry, that is the curvature of the anterior cornea, but we are putting the lens inside the eye, so we need the power of the total cornea. So how have we managed to measure only the anterior cornea but get the power of the total cornea? I think that is something that you did not talk about. Can you explain this, or would I explain it?
So basically, it is based on an assumption of that all the corneas have the same refractive index. So that is not true for every patient. So that is one caveat of this thing, that the refractive index of all the corneas have been assumed, and that is how we calculate the surface power of the cornea.
No,
I think that is what
I
that's
think
not the
understand.
I
situation.
think
See,
uh,
yeah,
I
You
think
can
he's
add more.
missing the point.
yeah.
No.
Yeah.
Vaibhav, he's brought out a very, very important concept, which, yes, it is a wonderful point of discussion. And that is the difference between, let's say, when we are doing a biometry by an immersion technique or a scan and the IOL master. Am I right?
Yes,
That is
no,
what he's trying to
yeah, no,
hint at.
what
And
I'm
please go
trying,
ahead.
yes,
All
ma'am,
of you
what
go
I'm
ahead.
trying to say is that, see, what is done is this should be understood, okay? So, because we were measuring the anterior cornea and we were not measuring the posterior cornea, but we needed power from the total cornea. So, how did the people who developed the formula, how did they take it? What they did was they did one simple modification. They changed the refractive index of the cornea. So what they found was that the actual refractive index of there's the most of the corneas have the same refractive index. It's not different. Okay, it's 1.37 only. But what the formulae found out is that if we change the refractive index of the cornea from 1.37 to 1.33 and then do the calculation, then even if we are measuring only the anterior cornea, we are getting the power of the total cornea. Okay,
That
because
means possible.
there is, yes, ma'am, because there is a fixed relation between the radius of curvature of the posterior and anterior cornea, and that doesn't change in any situation except in post refractive eyes, which we'll probably not discuss here. But in normal situations, the anterior and posterior cornea have a fixed ratio of radius of curvature. That is, the posterior cornea is, it is more curved than the anterior cornea. And based on that ratio, we've got that you change the refractive index from 1.37 to 1.33, then you can measure only the anterior cornea and apply it. So if you'll see in all your formulae, you have an option to choose the corneal index. You can choose 1.3375 or 1.332, and this is basically coming from how the formula has derived its the whole thing. So this is something that is important I wanted to bring out.
That's great, Dr. Zen. I didn't know about this. This is wonderful. I've
Yes.
also learned this
So
very
even
nice.
the IOL master, ma'am, is only measuring the anterior cornea, but the IOL master 700 is measuring even the posterior cornea.
Posterior cornea.
But
So
the
I was getting
formulae,
at that.
yes, ma'am, but the formulae have all been derived for the anterior cornea only. So we don't do posterior cornea in normal situations
Yeah,
because we have to
very
follow
nice.
the formulae which have been coming from the early days.
Very nice. Very nice. I really have enjoyed this little bit that you have talked about, because we always used to depend upon the posterior cornea. I know you were talking about the posterior cornea, but the derivation, how it has been derived, is a wonderful concept. Very
Right.
nice.
And there's one more little slightly more advanced on the same aspect is how is the posterior cornea normally in terms of the astigmatism. So normally the posterior cornea is more steep vertically in the vertical meridian and it is more flat horizontally. So because of it being more steep vertically, the posterior cornea is refracting slightly less in the vertical meridian and refracting slightly more in the horizontal meridian. So whenever we are seeing a with the rule astigmatism, we are taking that with the rule astigmatism from the anterior cornea. So let us say a patient is showing with the rule astigmatism of 1 diopter at 90 degrees. It is steep at 90. But if you take the effect of the posterior cornea, it is refracting slightly less in that meridian. So the total power would be around between 0.5 to 0.75, and it is exactly opposite for against the rule. So if it's against the rule astigmatism, meaning it is steeper horizontally, then the posterior cornea is actually more less steep horizontally, so it is refracting more. So a with the rule astigmatism is always has to be underestimated, and an against the rule astigmatism always has to be overestimated when we are doing toric power calculation. So this is another application that can come from the same concept.
Very nice.
uh,
Good learning.
yeah, ma'am. Also, one more point. Let's talk also about the camera systems that you were discussing about the beam splitter. A very important point that you brought out. So, when you have the operating microscope camera beam splitters, most of them are either 80-20 or 70-30, meaning 70% or 80% is going down and 20% is going to your camera. And that is enough because we are giving complete illumination. So these are all high light situations. So when there is more light, you're even if you give 20% to a camera or side scope, it is okay. But as you said, ma'am, that it is slightly not as clear in the side scope as compared to the operating but that is fine. But now where this becomes important is when you have a beam splitter in a slit lamp. When you have a beam splitter in a slit lamp and you use a camera, a beam splitter which is giving 20% to the camera and 80% to yourself, that 20% becomes very less if you are making a slit illumination. So if you are doing a slit, your image is always going to be pixelated unless you have a DSLR camera which can capture low light. So you need a good camera to capture slits. Or otherwise, like, if you see these Appasamy slit lamps which are coming now, where they are giving with the imaging system, they are giving 50% light to the camera and 50% to the observer. So if you see from one eyepiece, you will see it much dimmer, and the other eyepiece will be better because they have to give 50% to the camera. Otherwise, the camera will not give a good slit illumination. So that percentage of light that is going for the side scope is important in slit lamp and in the microscope. So this is another thing that we can discuss from
Very
this
nice.
presentation.
Yeah.
Dr. Vaibhav, any other points you wanted to discuss, Dr. Navneet?
I think he's had a elaborate discussion and it was a good lecture. So I think we've covered all the topics.
And
Sure.
I'll tell you this, that I've learned from you guys. It's very good. Lovely.
Yes,
The
ma'am.
topic was, Dr. Zain, it was very nice.
Yes,
The
ma'am.
points which you brought out after his elaborate lecture, which he talked about every little detail, that any person reading it or hearing it will understand, right? And after that, the points that you brought about were very nice because they have so much of clinical application. So it was very nice. Lovely discussion.
Right,
Just
ma'am.
wanted to carry forward the discussion with Dr. Zain started. That initially we used to consider that a steeper K, like 0.75 steeper K, we should make the incision in that axis,
Yes.
and then the astigmatism will get corrected. But newer toric formulas have started incorporating the posterior change in the posterior curvature as well. And what we used to assume the SIA as 0.5 or 0.25 for everyone, the concept has changed a lot. And the standard actually has now gone to only 0.12 or 0.14. So that is one more thing I think the postgrads may benefit. And if Dr. Zain or Dr. Sagarika or Dr. Navneet can add on this concept of adding and this posterior curvature into this.
No, I think, see, the surgically induced astigmatism becomes a little, drifted away from this particular. We can discuss this on the phone maybe sometime later. But yeah, what you said is important, that posterior cornea is now playing a role. So where it is playing a role is in post-refractive eyes, actually. Okay, so what happens in post-refractive eyes is that our traditional formula used to assume a fixed ratio between the curvature of anterior and posterior. But when you do a LASIK, you are flattening the anterior cornea. The ratio has changed now. The posterior curvature is now much more curved than the anterior. Okay, so because of that, those formula fail. So in post LASIK eyes, you need to actually do the measured posterior cornea from IOL Master 700 and use the formula, or otherwise you have to put in a true K formula. So a true K formula is one which will take some factors into consideration and then do the final calculation. But you cannot assume a fixed ratio between posterior and anterior cornea after LASIK has been done.
True. Absolutely.
So yeah, that was a great discussion, and ma'am, you had so many inputs as well, and I thank CFS and iFocus for holding these meetings. I don't think anyone holds such optics related series. I've not seen anyone hold something like this, and it really helps us to go back to basics. And so thank you once again for this incredible opportunity.
Thank you everyone for the opportunity. Thank you.
Thank you, all of you. Lovely meeting you all.
Thank you.
Never mind if
Likewise,
it's on a this thing virtual platform, but uh, everyone thinks that okay, the senior person will know everything. No, we don't. We learn from you guys. It's wonderful. So,
ma'am.
so once again, thank you all so much, Navneet, Zain, Weber for an excellent presentation. So much of hard work, so much of effort, because I know to make one presentation how many hours it takes, and then but the important thing in making a presentation is you learn with every slide that you make. So what your concept was perhaps when you were a postgraduate, and now as a senior doctor, perhaps you find that no, you have learned much more while making this presentation. So thank you all and good night.
Thank
Good
you.
night.
True.
Thank you,
So
Dr. Vaibhav, for such a comprehensive class. Thank you, Sagarika ma'am. Thank you, Dr. Zain, for discussing such a good topic in such an elaborate manner. And let's hope our students did get to learn a few new things and keep on learning. Thank you, everyone.
Thank you.
Thank
Thank
you.
you.
Good night.
Good night.
Good night.
Good night.